Now, there's the next type of reconstruction, breast reconstruction you mentioned, which is flap, using your own tissue, autologous. Tell us a little bit about that.
So flaps have been around for a while, but as with any technology or any technique, they've been refined over the years. So the initial flaps were actually what we called pedicle trams, and that's a kind of a fancy word, but the
The blood vessels are attached.
exactly the blood vessels are attached, and initially the anatomists saw that the blood vessels go through the muscle into this tissue on the abdomen that can be used for breast reconstruction. So it was transported by turning the whole muscle up and bringing the tissue up to the breast for a breast reconstruction. Now, as surgical techniques advanced, then microsurgery came around. And microsurgery is the process by which we can isolate specific blood vessels, disconnect them, and then re-sew them under a microscope. And so when that technology or that technique became widespread, people did what's called a free tram. And a tram stands for a transverse rectus abdominis myocutaneous flap. And that's a fancy word for using your own tissue down in the tummy to build a breast up top. Now, as surgical techniques further advance, we realize that instead of taking a piece of muscle where the blood vessel comes through to the tissue, we can actually dissect and specifically locate that vessel and spare the muscle, either all of the muscle or most of the muscle. And so that's called a DEP, or deep inferior epigastric perforator flap.
And that where you take, you isolate the artery and vein, and you take some amount of abdominal fat. Now, this is hard if the person has very little abdominal fat. So it's only good for certain types of patients, or how do you decide who is good for what flap?
So in our practice, we offer both techniques, so both implant and free tissue transfer or free flaps. But really, it's up to the patient. And then with our guidance, sometimes patients just aren't a candidate, depending on how much tissue they have. So if you have a very athletic patient with no tummy fat at all, then it'd be very hard for her to have a flap reconstruction.
Now, the flap reconstruction, there's also stages. So the same type of stages?
Right, the same 4 stages apply, which is the first stage is the creation of the breast mound, and instead of putting a tissue expander, we put in their own tissue or the flap. The second stage is revising the flap, sometimes to get it to the right size to match the other breast, and also do the symmetry procedure. The third stage is to create the nipple, and the fourth stage is to tattoo the new nipple areola complex.
So usually the patient can expect for the entire process, even though some of it's done outpatient, it takes a while to achieve all this. So probably.
So a typical 4-stage reconstruction will probably take about anywhere from 6 to 9, maybe even 12 months, depending on if they need any adjuvant therapy. But now there's actually new techniques in nipple-sparing mastectomy, where the nipple areola complex can be preserved. And in those patients, they essentially don't need to do stage 3 and 4 because they don't need to make a new nipple or tattoo an areola because they have one already. In those patients, sometimes they can even complete their reconstruction as early as 3 months.
And when, with the flap, that's the time you do not use this tissue.
Right, so the flap would replace the tissue expander, because after the mastectomy, where the skin envelope is preserved, you don't have to put an artificial spacer in. You will use the patient's natural tissue and actually begin to reshape and recreate a new breast mound.
Okay. Now, all these procedures are done with increasing frequency because obviously microsurgical techniques have advanced, and the popularity within, I guess, in California, where everyone's very fit and physically fit, so there's not a lot of abdominal fat. So is it more people opt to do this expander and the implant?
The national trends are probably that the majority of breast reconstructions are probably done with tissue expanders more than flaps, and there actually are institutional and regional variation. But I think the most important thing is when the patient comes in, that we discuss all the options of reconstruction and try to find the right one that fits them, fits their lifestyle, and that fits their body.
Now, if they have this tissue expander and then they have either one of these implants, what is the lifespan of these implants? Forever?
As you know, Gloria, nothing lasts forever,
Right.
right? So these are man-made, obviously.
Right.
So there's no finite lifespan. There's no timer or expiration date. But obviously, the longer the implants are in the body, the higher chance that there can be a mechanical complication like a rupture. So the important thing is that these breast reconstruction patients are patients for life, and that we continue to follow our patients on an annual basis, and that if there is any issue where the implant needs to be replaced, that it can be done and detected early.
Is it usually that the implants are redone after 10 years, 20 years, or?
You know, implants are medical devices, so they, you know, like we just talked about, they do have a finite lifespan. There is no hard number where somebody has to come in and immediately have it exchanged. The reason why the 10-year number seems to be floating around, or people talk about that, is during the FDA trials for the cohesive gel implants, patients had a risk of kind of reoperation or some sort of procedure 5% every year. So at 10 years, half the patients will have had some sort of reoperation on the breast or related to the implant.
Which one is the cohesive gel one?
That's the one on the far,
that's the
far right.
cohesive
Yeah.
gel.
Right, and this is even more cohesive. They're both cohesive, but it's just different grades of cohesion.
Oh, okay.
So with these options available, what factors into a patient's decision when choosing between these two implants?
Between the cohesive and the highly cohesive. Sometimes it has to do with anatomy in the patient, and as you can see, this one has a little bit of an anatomic or teardrop appearance, but it also it looks a little bit quote unquote fuzzy because there's a texturing because you want to keep this in the same position. Obviously, if this one rotates, it's okay because it's symmetrical, but this one, if it were to rotate, it would have an abnormally shaped breast. So.
Did they purposely make this with texture so that the growth of new tissue fibroblast formation would keep it in place?
Because it's anatomic, you have to have all texture devices, as you can see, all anatomic devices, as you can see, the tissue expander is even textured as well, need to have a texturing to prevent malposition or rotation.
So this, which is smooth,
Right.
this can rotate more easily.
Well, we still try to keep the pocket precise, you know,
Okay.
but if it were to quote unquote rotate within the pocket, it's not as critical as
because
anatomic
it's totally.
because it's symmetrical. So in any kind of configuration, it'll always maintain the same shape.
So this type of gel, is this the latest model? And is this like every time they change the gel, it goes through more FDA approval? Is that what happens?
Yeah, so all new implants need to go through an FDA approval process. So
So-
this was, I think, approved in probably 2006, and the gummy bears are just coming out. So two of the companies, Allergan and Mentor, are still pending FDA approval, and that's a third company that just recently got FDA approval, I think, in April.
So after, let's say, having 10 years of having this type of implant, the breast cancer patient who's a survivor and has done well, what are they to expect? Do they, besides seeing you once a year, what are they supposed to look for problems?
Well, a breast cancer patient is always a breast cancer patient, and as a survivor, they should always continue to monitor, especially if they did not have a mastectomy on the uninvolved breast. They still should undergo annual screening, mammography, and breast examination as directed by their breast surgeon. And also, if they do have an implant reconstruction or a flap reconstruction, if there's any issues where the reconstruction has changed, then they need to follow up with the plastic surgeon so that we can make any adjustments or replace the implants as needed.
And when they replace the implants, when you usually use obviously the same size, or you have to kind of revise everything because there's scar tissue?
It depends. Sometimes it could be both. And obviously also patients change. Their tissues change and the shape of their breast may change as they age. So at the time of the revision, we will assess